Hi, I'm Dr. Isaac Alexis from the Slim Samurai Group 84, helping you to slash through sickness and offering you a slice of health and wellness. Topic we're going to talk about today, my fellow Slim Samurais, is opioid epidemic, the 3 treatments now. Opioid epidemic, the 3 treatments now. As you know, some 140 people a year die from opioid overdoses. 140 people a day die from opioid overdoses. And it's a critical matter, with some 70,000 people dying from overdoses in 1 year alone, from 2019 to 2020. We're going to discuss via the latest clinical algorithms the effective and most effective ways to manage individuals with substance use disorders. I'm going to have the algorithm flashed for a moment, and you'll be able to better appreciate the stepwise approach in the management of individuals with opioid use disorders. Now, we'll start off first looking at non-pregnant adult with a history of opioid dependence who is physically dependent. Now, you may say, what's your definition of physical dependence? Physical dependence is when your body as a whole becomes used to the effects of a drug, and it will go into withdrawals when you stop using that substance. Now, if a person is not physically dependent, in this case, if they're not physically dependent, they may be having a mild craving. In this case, I will recommend addiction counseling plus injectable naltrexone. I'm going to go into the doses of naltrexone and the 2 other treatments in just a bit. Now, if a person that's physically dependent and they are past the withdrawals, I would consider a long-acting injectable naltrexone, which is the opioid blocker. And I'll discuss the dose of how many milligrams the long-acting naltrexone is comprised of. Now, if they are currently using and they're not post-withdrawal, then you would do what's known as transmucosal buprenorphine. So that is something that you must know. Substances like Suboxone, for instance, fall into the class of transmucosal buprenorphine. Now, if a person who is past withdrawals, and I mentioned they'd have to be on long-acting naltrexone, and you have to have all opioids out of your system, usually at least 96 hours out of your system before even beginning naltrexone. Let's say after they've been on naltrexone for, let's say, approximately 30 days, and still having cravings, and it's increasing the cravings, then that is considered pretty much a treatment failure on long-acting naltrexone. I would then start the buprenorphine naltrexone combination on Suboxone. Now, the next classification to consider is if there's treatment failure. They're having constant urine drug screens are constantly positive for opioids, whether it be morphine, whether it be OxyContins. So treatment failure, and that treatment failure could be secondary to they had such a high level of opioid use. It could be fentanyl abuse, Opaner abuse, OxyContin abuse. And so this Suboxone is not working for them. In that case, if the Suboxone is not working for them, then you consider a change to methadone. If they're still showing physical dependence, meaning the body's still going into withdrawals, so you still need it. Now, if they're not going into withdrawals, then you may consider a change to a long-acting injectable buprenorphine complex, such as Subutex. And if they fail on that, then you may consider changing to methadone. After all is said and done, if they're on methadone and there is treatment failure still, meaning positive urine tox screens for 3 to 6 months, then you need to add more intensive psychotherapy counseling. But I want to throw it out there. There's a lot of treatment centers that just want to keep people on Suboxone forever. And I want to say physicians, nurse practitioners, physician assistants, that is not the best use of our time. We have to do the best for our patients. And we don't want to trade one drug for the next. And so in some cases, if the patient has a mild craving, injectable naltrexone is the best option. I left a company that tried to force down my throat indiscriminate use of Suboxone. I won't have any of that. And so my patient comes first. My cousin died of a drug overdose, and I'm passionate about the evidence-based guidelines on addiction treatments. And I don't pull back the punches when it comes time to giving people the best care that they deserve in substance use disorders, specifically opioid use disorders. This is something that is critical, and we have to take very good care of our patients. Before I continue, don't forget to click on the like, subscribe as well. It says 25 of your patients, 25 of your friends, family. Also, comment so I know what to talk medically on the next topics. Okay, now let's look at those 3 medications used in treating opioid use disorders. Number 1, naltrexone. You can start at 25 milligrams once a day for 1 to 3 days. And if no withdrawal signs, administer 50 milligrams once a day thereafter. If you're going to go the once a month route, it's an intramuscular injection of 380 milligrams. You inject once every 4 weeks. Very critical. And before starting naltrexone, you should not have had an opioid of any type, including codeine, cough syrup. That's common in cough medications. You should not have had any kind of opioid for at least 5 days. Number 2, we're going to talk about buprenorphine naltrexone. Film tablets. You initiate 2 to 4 milligrams. We use objective scale, clinical opioid withdrawal scale, called COWS. Not the type that gives milk and chews grass, but the other type of COWS, the clinical opioid withdrawal scale. I'll go into that in the next module. But anyway, you start at initiation of 2 to 4 milligrams. If no signs of withdrawals, you increase by increments of 2 to 4 milligrams. You don't just slap it on the patient and have them to just overdose on you like that. You increase that by increment of 2 to 4 milligrams. And once that initial dose is tolerated, you may increase to a dose that's clinically effective and provides the patient with 24 hours of stabilization. Doses greater than or equal to 8 milligrams a day in many cases are necessary. In patients continuing to use opioids, I would increase the dose by 4 to 8 milligrams, thereby reaching a daily dose ranging from 12 to 16 milligrams. Maximum daily dose is 24 milligrams, but the studies have shown that looking at receptors in this partial mu agonist of buprenorphine, 16 milligrams, has been efficacious to where you don't need the 24 milligrams a day. Less is best. You want to get and titrate these wonderful souls and patients off of the Suboxone if necessary. Everything is on a case-by-case basis. Now, methadone, usually initially 20 to 30 milligrams as a single dose. When there are no signs of sedation and patients showing signs of withdrawal. Maximum initial dose of 30 milligrams. I'm going to go into detail in my next video, the stepwise dose initiation of methadone in more detail. And this advice that I'm giving in general is not to substitute for seeing a substance use medical professional. You must venture out and get that professional medical consultation at your local MAT clinic. But naltrexone is a viable option, and I encourage that for persons that have mild issues with opioid use disorder, that have mild cravings, let's say for the past 6 to 9 months. They may not need the initiation of buprenorphine, naltrexone, known as the Suboxone. So that's just something to keep in mind. Okay, Slim Samurai family, hoping this was of much benefit to you during the opioid crisis. I'm Dr. Isaac Alexis from the Slim Samurai Group 84, helping you to slash through sickness and offering you a slice of health and wellness. Don't forget to click below the subscribe button. Comment, send to 25 people as well, and click the like button. God bless.